Okay, so this patient, so I don't want to go into, directly we'll go into anatomy and, the role of IVUS, or how IVUS has to be used in this case. So you can see there is a proximal LAD lesion and significant lesion. You can as well see the calcium, and which in angiography appeared to be kind of medial, I think deep calcium, but anyway, we'll see what IVUS is showing. And we can also see another lesion in the middle LAD. Okay, so I'll show you even epicranial view. So you can see this is the epicranial view. There is a middle LAD lesion, and there is proximal LAD lesion at the diagonal, a big diagonal, and so okay, you can start doing IVUS, please. Yeah, IVUS, please. Yeah. So this is the anatomy. So, and the questions here is where is the distal reference? So where is my distal landing zone in LAD? That is one question I have. So another question is proximal LAD bifurcation. So what should I do to ostial diagonal? Do I need to protect ostial diagonal or not? So, or do I need to, do a provisional stenting or, through some strategy? So that's another question which I have. And the next question I have is, how is the proximal ostial LAD? So, whether I can land, stent in ostial LAD or not. So, what is the proximal LAD, lumen area, plaque, and what is happening to plaque extension into LMCA? So, whether LMCA there is a plaque extension or not. So, these are the questions I have. And next, what I wanted to know is the MLA of LMCA. So, we did both IVUS from LAD and LCX, which we start analyzing systematically, and then we'll answer all the questions which we have. I need to answer what is the ostial ostial LCX area, and do I really need to protect if I had to stent from LMCA. So these are the questions which I have to answer in IVUS before jumping on to the kind of strategy. Okay.
Hello, Dr.
Right.
Sir.
So I'll move on to the questions which I have to answer in imaging. So first come to LCX, because that is something which I have to clear before you move on to LAD. Show us the LCX and show us how you identify LCX and LMCA LAD ostium.
So now we are taking the LCX IVUS and it's a pullback. I'm Dr. Damodar. I'm interpreting the IVUS here. So you can see now we are reaching the LM bifurcation, and
shows the LAD, please.
So this is LCX, and when you pull back, this
is IVUS from LCX, okay, and you can see at 2 o'clock a branch is joining here. You just go back and come back again. They'll understand. Now play again.
This is LCX, and
play again.
We are moving from distal LCX towards the bifurcation LM. Here you can see there is a branch, and we are moving into the bifurcation zone and the LCX.
Yeah, you can see that wire is the wire which is joining. Please go back. Yeah, can you see a wire at 2 o'clock?
This is the wire which is coming from LAD.
That is LAD. Now you pull your arrow onto the LAD, and you can see in longitudinal view. See, are you on LAD, please?
Yeah, this is LAD.
Yeah.
The LAD
so now you can pull it back, go back. Yeah, that is kind of ostial LCX. Go back.
This is LCX.
Yeah, this is a kind of ostial LCX. So you can see the area of ostial LCX is 7.6 mm square, right? And the plaque area is 38%. So with such a lumen area, plaque area 38%, see, there is no need to really protect this LCX. because I was from LCX, I want to move my wiring to a diagonal. So that is the reason I am discussing, LCX ostium first. So the conclusion from this IVUS, so you have a good lumen area of ostial LCX of 7.4 and block area of 38%. So I think, see, we can, there is no need to, mostly there is no need to do anything to it. And if you can quote some data, so any ostial LCX more than 4.5 mm square, so mostly, you can just do a provisional side stunting strategy, if at all, if you are extending your stunt into LMCA, which we'll address later. Okay, so
Pull back from LCX, so this is distal LM areas. You can see
from LCX,
it is.
From LCX, next minimum lumen area, please. Show us MLA, which we have discussed, before. So you have to always assess both from LID as well as LCX. Okay, so you can reduce at 3 o'clock a little more. So
3 to 6 you can.
yeah. So I think it's around 7. Okay, it's around 6.9. So the question here is, see, this is from LCX now, and the block area is 72%. Now we'll move on to IVUS from LID. Please move on to IVUS from LID and show us only LMCA MLA first, because you see in IVUS you need to answer your questions. Okay, you have to have questions what you want to answer, and then you go step by step.
This
Only
is
show us LMCA. So this is a distal LM 8.1. This is 7.9 next, and this is 7.4. And this is 9.9. So as I already discussed, from LCX it is 6.9, from LID it is 7.4, your MLA, right? So now the MLA is 6.9 and block area is 70%. So do we really need to cover it? So that's a big question, which we have to answer. Do we really need to cover this LMCA? What, data says MLA, if it is beyond 6 centimeters, 6 mm square, so by MLA wise, there is no need to treat this LMCA. Block area has no significance in LMCA, and block area never showed any changes in outcomes in long run. So by MLA, I think this LMCA we can leave it. But the question is, when you are coming from ostial LID, what is the extension of block here? So we had to stunt proximal LID. Now we'll show you from ostial LID. Show from ostial LID.
This is ostial LID, sir.
Just go a little bit down. Just play it. So we are playing from proximal LID. You can keep watching, right? So there is a lot of block from 12 to 6 o'clock. You can see there is calcium, and this is LCX. Okay, can you see here at 6 o'clock? That's a LCX ostium. Now you go back and tell us the block areas and the MLA.
So this is ostial LID.
Yeah. So this is the MLA at ostial LID, that is 4.5, and there is block almost 65% of block area. So when I'm stunting that proximal LID lesion, and if I end my stunt at a 65% block area, that is at the ostial LID, I think this is a kind of geographical miss. Obviously, this patient will have higher chances of restenosis, and there is every chance he might come back for another intervention in near future. So, and now you can see the block extension into LMCA. You can play here. So if the block is extending into LMCA, right? I think more than 3 millimeters into LMCA. This is the block extension is there in entire length of LMCA. Yes, there is a huge block area. Yes, the lumen area is minimum lumen area is 6.9, but its extension is huge into up to the ostial LMCA. I think now the answer is with you. I feel here I have to extend stunt from ostial LMCA into LID. So now we'll discuss what about calcium at the, see, you can see a lot of big calcium in the proximal LID. Please show us calcium at the proximal LAD. You can go
So
back
the
and
calcium.
describe all the calcium, please. Go back. Yeah, this is the area. Okay, this is
here.
the area. Okay.
So the calcium is starting from this area.
Yeah, you can keep playing it, and if you can tell the size of the
So,
EM there.
The diagonal ostium we are seeing
Okay.
is almost more than 180-degree arc of calcium.
Diagonal.
So this is the distal LM and this is the ostial LAD.
Yeah, one glaring point here is if you guys has observed calcium appeared deep in angio, right? But on fluoro. So, but now you can see the calcium is there even in the lumen there, okay? But what is the arc of calcium, Damodar?
Sir, is around more than 180 degrees of arc of calcium, sir. And here you can see it is more than 270 degrees here. Almost nearly, only this part is free of calcium and almost it can say more than 270 degrees at this location. And one more thing to say is, to measure the, we have IVUS calcium score where so if there is 360 degrees of calcium with the visualized calcium and angiography, give a point of 1. So this adds 1 point, and also here we can see 270 degrees of calcium, so we have to measure the length. So length is more than 5 mm from the proximal LAD, so this adds 1 point.
Just give me the 2 point.
In the middle LAD, when you take the diameter, so it's nearly average EM diameter is around 3.5, so it's a good sized vessel, so here the point would be 0. And we don't see any calcific nodule, and IVUS calcium score in this IVUS interpretation comes to be 0, so this patient requires some kind of calcium modification.
What is the score?
2.
Yes, so you can show at the calcium area, show only calcium area, that's a proximal lesion. This lesion I'm not really worried about. So play.
Proximal lesion.
Yeah, just play. You can see the calcium is definitely superficial as well as deep. There are both deeper one we can't say in IVUS because it can't penetrate, but there is definitely a superficial calcium, but it's hanging around 180 degrees here. You can see. Go back again and show. Go back again and show. And if you see the length of the calcium, so it's around 5 millimeters. So this is the area where it is almost like 360 degrees, and that is the reason I think it becomes 2 calcium score and length and 360 degrees. I mean at one place. Because it is superficial, and yes, I have also issues with affordability. So I'm going ahead with cutting balloon here. I think, see, we can do rotablation as well, but we can do cutting balloon as well. So this area, I think mostly I'll do a cutting balloon, but what size, that I have to decide based on the EEM. So can you show us a good EEM beyond diagonal, please? Yeah. So always go to a place where you can see a good EEM. When there is a calcium, you can't really see EEM. He will show you, Damodar can show. We can't see EEM in the calcium area. Please show the calcium area. Please show the calcium area. Please show the calcium area. B6. Yeah. You can see here. You can't see anything, beyond calcium. So now go to your good area where you can see EEM.
Yeah, this area.
Now you give us the size. Based on that, we'll take, tell it again, please. I tried sending IVUS into diagonal, but it didn't go. Okay, negative, right.
You are pre-dilating the diagonal.
Yes, because it was not going. I'm just pre-dilating. I'll try again, try and send IVUS. Okay, give me IVUS. What is the ACT, please?
EM average comes to be 3.4, sir. EM average diameter.
Yeah, it's a 3.4, right? So, see, generally cutting balloon, with E, I'll take at least 0.5 mm less than, EM size, okay? That's 3 will be my choice here. I'll take a 3 cutting balloon. If you can see EM in the area of calcium, then it becomes a bit easy. What is this? Give me flextome, flextome 3 millimeter.
We are going with 3 cutting balloons, sir.
Right. So now for me, the remaining question here is about diagonal. So what should I do? This is a big size diagonal. So I want to study the ostium of the diagonal. I tried sending IVUS into diagonal, but it didn't go. That's why I just dilated. So it didn't go because of the LED lesion, not because of the diagonal lesion, but I'm just trying. Okay, thank God. So it just went in. Now, after dilatation, so let us see. Yeah. Please inject. Please inject.
Some amount of fibro.
There is some
Fiber
dissection.
with fibrocalcific block here.
Man.
Around significant calcium noted, around 180 arc. So we are entering the LED.
Okay, I'll stop. So my interest is only ostial diagonal. So let's evaluate ostial diagonal. So already we did enough on the LED side. So give me a flextome, please, for proximal LED. Yeah. Yeah.
315, sir.
What is the size of ostial LED? Yeah, give.
Ostial diagonal. LED.
Ostial diagonal, please.
We are at the diagonal, sir. Ostial diagonal. We are getting a area, lumen diameter, lumen area of 3.6.
First, keep a distal reference in diagonal, please. Go down, please. Down, please.
Is good enough.
Yeah, keep a reference here. So this is the reference. So I think there is some flock area here. So I think that's okay. Yeah, okay. So I'm just going ahead, while he's assessing ostial. Yeah, okay, this is a cutting balloon flextome. So you please inflate slowly, please. Yeah. Inflate stepwise. Yes, slow. 2 set. Yes.
6 on
4. Yeah. What's 6?
6 on
RBP is 4, right? So go to 8.
8, sir.
Yeah. 10. Okay.
10, sir.
So this is flextome, that's cutting balloon, which I'm doing there. Yeah, down, slow. Okay. Yeah, just dilate. Go to 10.
6. 8.
3 millimeter.
3.
Because that place, we don't know the size as well because it's all calcium. So we are only taking size from distal reference. So distal reference. Okay. Meanwhile, so what is the ostial LED? Ostial diagonal area, please.
This is the ostial diagonal. 3.28 is the lumen area.
No, go back, please. That is not ostial diagonal. Go back. That is ostial diagonal. Okay. So you can see the wire in LED, right? At 4 o'clock. Okay. So that go back. Yes. Back. You play from there, I'll tell you. You see the wire in LED. From 3 o'clock it is coming and joining. Yeah, can you see that? It's LED. So this is the ostial diagonal. You can see there is even some dissection flap, and you can EM size, please. And the area is almost 4 mm square. Okay. Yeah.
So this is the dissection flap
please.
here.
Give us MLA and then give us EEM, please.
6, 8.
I mean, again, I'll just quote some data. You know what data says. I think it's 2.5. Anything beyond 2.5 mm square usually. Okay, give me some NCG, please. Okay, right. Give me some NCG, please. Now I think we have to move on to. All right, so you can show that dissection area, right?
So
See,
this area is
generally side branch, we see a bit differently. This is a bit tricky side branch. So, I mean, we have two approaches here. One is yeah. See, basically, is MLA is quite okay for me. So, based on MLA, my decision would be, you can leave it. But the flap, you can see the length of the flap is very short, which Damodar can show you. And if you see the overall angle, it is also like around 30 degrees. Yes. So yeah.
starting
So,
here, sir. The dissection area. Yeah.
So 30 degrees. So man, this is like a gray zone. You can, if you want to avoid the two stunts, you can leave it and you can go move on to provisional side branch stunting. And if there is any issue again, you have to do either tap or T based on the angle. Okay. Come to epicaudal.
Can you appreciate
Come
it?
to epicaudal.
Yes, sir.
Keep stunts ready, please. What is the distal difference? Can you go back to Astel LAD? I think the distal portion. Distal portion, please.
Lady, sir. This is the distal lady reference segment.
Yeah.
Lumen diameter average is 2.45.
Okay.
We can take a.
What is the size?
You can take 7.5 comfortably, sir.
2 point.
7.5.
Okay. 2.8, 3.2, around 3 you are getting. So I think we can take even 2.5 as well. What is the length? Length below the diagonal. You take up to diagonal, what is the length? So you can see the diagonal at B5. Okay. Yeah, stop there. I think it's 48. Just give me, right. But is there any landing zone in the middle?
Yeah,
Because we can see some landing zone in the middle.
landing zone
Yeah.
is a block, and we can
Go
land
down.
here.
Go down. At B3 there is some landing zone. B3. What is the block area here? Okay. B2. What is the block area here?
Yeah, less than 50%. around
50%. So I can use that, right?
Yeah.
So B1. Okay. So I think that's fine. So B2 can be my landing zone. From B1, what is the length up to B5? So and what is the size at so B2 see. B2 can be landing zone and length up to B5, that is beyond diagonal. 42, right? So what we can do, okay, we'll take right, so this is a bit tricky situation. So what I'll do here is first I'll stunt LM2 LAD. Okay, now you give me Austal LMCA to diagonal length. Give me IVUS, okay? Keep some NTG on, please. Give me the length from Austal LMCA to
23.
Austal diagonal.
23.
Huh?
23.
23, okay. Please give us some stunt around 20 size, please. What is the size? The mother.
Yeah,
What
sir.
is the EM size at Austal LAD?
Sir, EM we can take 3.5 easily.
Okay. Yeah, so it's around 4, right? So we can take 3.5 easily. Yeah, records. Live, please.
I'm live.
I'm only doing, the calcium area. Please keep injecting. Keep injecting.
I think there are some cuts in the calcium.
And you also keep ready 3.5, 23, 28 as well, okay? Yeah.
It's to be a soft block in the LMCA.
Okay.
Stop.
It's in that.
Stop.
It's in guide, right?
Stop.
So stop. So now, we'll show you some trick of. All right, go to yellow cranial, please.
Take it.
Yeah. So locating ostial LM. Okay. This is something which is very easy with IVUS. Live IVUS, please.
I'm live.
Give me live IVUS,
Live.
and then you show them whatever they want. Okay.
Basically, force it straight.
Okay, good. Oh, inject. See, whenever image is not good, you have to keep injecting normal saline.
And the
Right?
guide.
Okay. See, you can see here, 3 to 6 o'clock, that is aorta, right? And you can see at 6 to 2 o'clock, that is LMCA ostium, right? So this is the right place, where I have to land. Yes, yes. And I'm taking first proximal stunt. So as I already explained you why I'm taking proximal stunt first. The most important reason here is, so I'm just again locating, sorry.
Sorry, you're in the guide.
Yeah, this is, yes, this is where I have to end. Okay. See, the most important reason is, we can't fix two ends of stunt, right? So if I have to stunt proximal second, my distal end is fixed, proximal end is fixed. Okay. And I cannot overlap stunt onto branches. There is a big diagonal. Okay. If I end up in overlapping onto diagonal, let's say, my first stunt I land below diagonal or above diagonal. Here I have to land above diagonal. And if my second stunt goes on to diagonal, then you are overlapping that branch with two struts, so which is not good. So you better put a proximal stunt first, okay, up to either end before diagonal or end after diagonal, okay, and then take your second stunt with overlap in that non-branch zone. You can see the zone before diagonal is there are no branches, zone after diagonal no branches. Now the question comes, where you want to end your proximal stunt. Is it before or after? So that depends on your that depends on your relative size of the vessel. So I'll take 3.5. So beyond diagonal, what is the size? 28 is okay. From LMCA ostium to beyond diagonal, 28 is okay.
Just a minute, sir.
Or should I take 33?
Just a minute, sir.
Beyond diagonal. Where is diagonal? First show me diagonal. I think 28 should be fine, right?
This is diagonal.
Yeah. So I think 28 should be fine. Give me 28, 3.5. But we are taking bit of larger size. You have to understand that. So we don't deploy it at full pressure. So we deploy it at lower pressure, and I'll bring the balloon back. Give me 3.5, 28 synergy, please. And what is a pod balloon, Damodar?
Sir, you can take 4.5 to you can take a 5 per pod balloon.
That's okay. You have to be patient enough.
EM average is around 5.4 here, 5.5.
So you can take up to 5, right? So you tell that.
So this is a LMCA section at the block where you can see this is the EM diameter 5.14 and 5.86. It's a maximum and minimum. And when you take average, it comes to be around nearly 5.4 to 5.5. So generally pod balloon is taken less than 0.2 or less than 0.5. In this case, to be maximum available balloon is 5. So in this case, we can go with 5 pod balloon.
Yeah, you have to check, please. So now what I'm doing, so I kept my IVUS image already up. All right. Okay. Wait. Okay. Just go back and show me. I'm showing you. You can see the IVUS. Yeah, this is where I wanted to land. Okay. So the tip. Just check again. Oh, I think I'm a bit out. Okay. Yeah, I think now I'm check, please. Yeah, that's perfect. See me, please. Okay, deploy.
2, 4, 6, 8, 10, 11.
Yes. Negative. Someone put police to fashion or some feeding tube or whatever. Customer. Okay. I'm changing my. Okay. This was not okay. So now I pull balloon back, before diagonal, so we'll go to full pressure now. Go to 14.
14, sir.
Yeah. Okay, negative. అయిపోతుంది. ముందు చేయాలి.